So I stopped. All this can occur within 24 hours. Even the patient was brought into the hospital seemingly injureless with only one little wound on his hand. All these steps have to be taken to rule out all the sequelae. Also, the iceberg effect. The point of entry is right here. I like to use my blue pen. So there's the cord, point of injury was here, and it's like an iceberg effect, spreads. Okay. And we moving on. So a little bit of pathophysiology of the burns. Okay. Something that I learned. Up. Okay. Okay, that's good. So we got superficial burns. So right here it divides deep burns, superficial burns. So the damage occurred, right? The damage occurred to epidermal layer or that superficial partial thickness, that second degree burn, or deep partial thickness, also second degree burn. So what happens? The damage occurred, the keratinocytes and cells in the in the papillary layer send the signals to the mast cells and macrophages to come to the area and to start repair and clean from the dead tissue, killed some bacteria along the way. Now I can make it larger for everybody to see. So macrophages also stimulate the nerves. Macrophages will release the cytokines and inflammatory mediators, and they will travel to the nerves and causing a positive effect and causing pain, stimulating the nerves. Also, macrophages will release cytokines that will request more white blood cells to the area and also dilate the blood vessels. So that's what main response of the tissues to that burn is dilating the blood vessels. So vessel dilation occurs, and there's vessel permeability is increased. So what happens? The vessel dilates and it allows fluid to leave. When the fluid leaves, it increases the hypotension. Not only there's fluid leaving to the tissues and leaking out, it also leaving into the interstitial space and causing edema. Okay, fluid also leaves to the surface, and it will the surface will be moist. Moisture will accumulate on the surface. That's why your first and second superficial burns will have characteristics of moisture and pain. So you will see warmth, erythema, redness, blanching when you press it, and pain. So that's what the whole pathophysiology with superficial burns, and they're treated mostly at home. They don't really have to go into acute care with this type of burns. They can be treated at home with different creams, different dressings that can be changed only once a day or even like once in 12 days, depending on the agent. Well, if they develop like an infection and that can lead to more damage to the tissue, and if it goes into sepsis, if they have a high temp and just weakness and hypotension, they should go back to the hospital, and probably, yes, they will be admitted to intensive care unit. Deep burns. This fella had a deep burn to the deep layers already. It's a 3rd and 4th degree, and maybe deep partial thickness, 2nd degree, or it's 3rd and 4th. So the burn penetrated all the way down to, let's say, hypodermis, and it damaged the blood vessels really bad and damaged the nerves. So again, cytokines will be stimulated, and they will stimulate vasodilation, and fluid shift will occur. Fluid shift will occur not only due to blood vessel dilation, but also because the burn that damaged was so extensive, it damaged the blood vessel and it opened up the blood vessel. So sodium will move out of the tissue and albumin will move out of the tissue, and it will be present in the interstitial spaces. So more fluid will be drawn. That second osmotic shift, when there's more particles outside the cell than inside the cell, so that will shift the fluid. And also albumin, the major balancing molecule inside the blood vessel, it will pull the fluid, and this all will lead to edema. So edema will be caused, but because so much fluid through several different reasons are leaving the blood vessels and systemic circulation, it will lead to hypertension and inevitably to shock, unless we provide them IV fluids, which usually they use lactated ringers. And then after, because they lost so much albumin, but I think after something like 24 to 72 hours, the blood vessels will repair themselves and close. Then we also will give albumin, 5%. So to treat that albumin loss in the tissue, and maybe some albumin will be mobilized too and come back. Okay, let's see if it's gonna stop right now at 8 minutes. My recording. It might not. No, it didn't stop. Okay, so destroyed blood vessels. So the nerves were destroyed. So there's insensitivity to pain, or I think light pressure, maybe even deep pressure. So wounds are dry because no fluid is leaving towards the wound itself, and it will look dark black, gray, white. No blisters because no fluid is leaving, no redness because no fluid is coming, no iron at the site, no redness. And they will be inelastic, that leather type, leather. No blanching, as again you press to see if you can push the blood out, and then the blood will return back into the area, and this will not occur because there's no blood vessel supplying that area. And loss of sensation, nerves are destroyed. Okay. Alright, so next diagram, again, just going over things. I'm gonna go over it several times until it sinks in. So we got our epidermis, our papillary layer, our reticular layer in the dermis, and hypodermis. So 1st degree burn is just that superficial epithelium is burned, and it's painful. So this is red, dry, painful, blanching with pressure. And we go to 2nd degree, superficial partial deepness burn. It occurs to that papillary layer. So this is papillary layer, papillary layer, and it is damaged. Again, what's going to happen there? We will see blisters. It's red. It's wet. We can draw some wetness. Painful because the nerves are still present. It's just injured. And it is blanching with pressure. We're going farther. Let's go deeper. Let's go farther. We got second degree deep partial thickness burn, not painful, involves reticular layer, and it is right here. So the thing is with second degree deep partial thickness is that it didn't go through the whole dermis. It did not. It went to the reticular layer. It damaged the reticular layer, but it didn't go through the whole reticular layer. That's why it stays the second degree. And then the third degree would be the whole dermis. The whole dermis, probably a little bit of hypodermis is involved. I'm not very clear on that, but that's my perception. That it goes through the whole dermis and a little bit of hypodermis is involved. And the second degree deep partial thickness, it went into the reticular layer in the dermis, but it didn't go through the whole reticular layer. If you want to comment below, provide me more information, I'll be happy to hear it. So third degree full thickness would be full dermis and some hypodermis. So, I didn't talk about deep partial thickness burn. So deep partial thickness burn, it would be whitish, could be yellow, could be red, and it could be blisters, or might not be blisters. So it's at that golden middle, that level where the blood vessels are present or not, is the nerve present or not, or they're absent completely. So they could be wet or dry. Usually they don't blanch, and pain due to deep pressure. So we go into third degree burns. So our whole dermis is destroyed, for sure. And we get, so that's third degree, waxy white, leathery gray black, dry, no blanching, painless, stiff and inelastic. And fourth degree is charcoal black. That's all the way to the muscles. Should be all the way here probably. Okay. They're charred black, dry, pain only from deep pressure, patches of dead skin are there. Okay. Then some of the, I found this on OneNote. OneNote provided this picture. So again, superficial, painful, no edema, redness, blanching with pressure. So that's redness, blanching with pressure, no blisters, partial thickness, blistered, moist, painful. There it is. And full thickness, dry, discolored, no pain. Simple summary. And a little bit in-depth summary. Alright. So, clinical signs of burnt wounds. So, let's see. So we got degrees of burns. First superficial, second partial thickness. That divides into superficial and deep reticular dermis. Third degree full thickness and fourth degree full thickness. So affected layers. We got with superficial first degree, we got epidermis. With second degree, we got just the superficial. Why didn't I include this? Papillary layer. Papillary layer. And then deep reticular dermis with second degree. We also have that third degree full thickness burn and layers affected epidermis and dermis. See? And then fourth degree is full thickness, skin, subcutaneous structures. So clinical signs and assessment. So we'll talk about blisters, pain and color, something that you can see, and the assessment that you can perform is to check the capillary refill, to press on it. As you press on it, do they sense the touch, and do they sense the pressure? Okay, I'll use the green and red to signify what is present and what is not present. So we go for superficial first degree, the epidermis. So because the fluid is leaving, oh, hold on. Because the fluid is actually still being retained by the body, by the tissues, so there would be no blisters. So pain is very bad because the blood vessels, nerves are damaged. Color is red because the blood vessels are dilated and they allow some inflammatory mediators to leave and some blood. So they will feel, when you press on it, when you press on the area, the capillary fill does occur. They do feel the touch, the nerves are still there, and then pressure, they will feel the pressure, and they will ask you to stop doing that. Maybe not, maybe they'll tolerate it. So second degree partial thickness, we got superficial papillary layer. So will there be blisters? Yes, there will be blisters, because fluid does leave and it forms blisters. Pain, very bad, the nerves are still there. Color, it could be red or white. Red or white. Capillary refill, when you press on it, the capillary refill will be present. Because why? Because the blood vessels are still present. And then touch, the nerves are still present. And pressure, they will feel the pressure. Then deep reticular dermis, that's where it's the line. That's what the line I talked about. It could be or it could be not. It could be present or it might be not. So damage to this second degree deep reticular layer, it might be noted or it might be not. The blisters, they might be noted, might be not, depending how much blood vessels are left. Pain, medium, more nerves were damaged, and it's possible that they will feel something, maybe not. Color, I wrote white, but it could be already the grayish, yellowish. Gray, yellow. Gray, yellow. Capillary refill. So when you press it, will there be capillary refill? Well, it's this diagram says it could be present, or it might be not. This is the fine line. So touch, no touch. You don't feel the touch. Their blood vessels are damaged. Nerves are damaged. Pressure, they will feel the deep pressure. It's a deep pressure. So third degree, full thickness. We got epidermis gone and dermis is gone. So that the vascular layer is absent. Okay, vascular nerve layer is absent. So I'll select my red pen. So blisters, there will be no blisters, no fluid leaving. Pain, there would be no pain, no nerves are left. Color, white, where's black, gray. Capillary refill. So you press on it, nothing happens, no capillary refill. You press on it, there's no touch sensation. You press on it again, there's no pressure felt. So 4th degree, full thickness, skin, subcutaneous structures, our muscle. So blisters are absent. Pain, no pain. Color, again, white, black, black. Capillary fill, no capillary fill. Touch, no response to touch. Pressure, you touch on the 4th degree. No pressure sensation. Alright. Talked about that. Glitchy. This little one too. Alright. Okay. So when the patient comes into the emergency department, they have to assess and diagnose the patient how much of the area was burned on their body. They measure it in the percentage. And this, the number that they will get will be very important. Very important. They will use this number to replenish the fluid in the body, because the body will swell like 3-4 times. That fluid will leave out of the blood vessels because they're damaged, and inflammatory mediators cause the blood vessels to dilate. So fluids will be very important to prevent the shock. And organ failure. So assessment and determining how many fluids is needed is what will be used. This formula, this diagram will be used. And this one, well, people have to memorize. And it includes only this formula, this diagram. You should assess only the superficial, you should not include the superficial burns. You should not include them. The ones that are red. And one area can have different types of different stages of the wound. So the one on the edges you would not count as the on the edges of superficial wounds probably will not become. More to the center where it's black and gray and leathery and they don't feel the touch. Oh, it's a good way to determine. You would press on the areas and you say, do you feel it? Do you not feel it? You have 2 hours to do that before they have to be intubated, but still you can probably use that, pressing on it. If they can't respond anymore or can't even moan, they will be probably moaning. So you, just by looking then, is there blanching? That's another tool. You don't even have to talk to them. Is there blanching? And is it red or other color? If it's not red, if it's yellow, black, gray, white, then it's past the dermis. It's 3rd or 4th. Alright, so you have to memorize that the head, the total, if the head is burned, just the face, it's 4.5%. If it's the upper chest, it's 9%, and if it's the abdomen front, it's 9%. So together it is 18%. Just the front chest of the, not chest, chest and belly, it would be 18%. Front of the hand, if the burn is sustained to the front of the hand, it's 4.5%, and the same on the other hand, 4.5%. The whole leg, front of the leg, is 9%, and the whole, just half of it, upper or lower, it's 4.5%. So the same on the back. The upper back would be 9%, and the lower back would be 9% together. It's 18%. The back of the hand is 4.5. The back of the head is 4.5. The back of the leg is 9%, and just if you divide the leg it would be 4.5 and 4.5. That genitalia together it's 1%. The perineum, genitalia, that area would be 1%. And I should mention that any damage to that private area or next to the anus is the greatest infection chance or risk, the greatest risk of infection, because there's your E. coli, there's your Enterobacter and all the other gut bacteria also on the perineum. How sensitive and blood rich that area is. So infection to that area, damage to that area would lead to the higher risk of an infection. So if on the test you're asked the patient sustained injury to the perineum only, what is their greatest risk? And is it risk of integrity, skin integrity? Is it a risk of hypovolemia? Is it risk of infection? So your answer should be infection. You should think about that right away because of the anus, because of the gut bacteria. So yes, you have to memorize this formula, and later on, once you get your number, for example, the person sustained injury to, let's say, right hand 4.5, they sustained to the chest 18%, and they sustained it to the right leg, so that would be 9%. You would get the number, is it 13.5, 18, you get 31.5. You get 31.5%. This number is going to be used in this formula. So you take the percentage of the body burned, you multiply it by their weight, and you multiply it by 4 milliliters per kilogram. So if you plug the numbers, let's say the person was 90 kilos. What is it? Multiplied by 2.2, you get the lb. You don't need the lb, you need kilos. It's kilograms. So it's let's say roughly 200 pounds. Roughly. I don't want to use the calculator right now. Okay, so it's 180 plus 2 by 9, 18, 198. So it's 198 pounds. If you want to know the pounds, it's just for the ease of comprehension. So you plug these numbers into this formula. So you get 31.5% burned multiplied by 90 kilos multiplied by 4. What do you get? Okay, let's use the calculator. Where's my calculator? I think it's this one. Okay, so we get, what did I say? 31.5 multiplied by 90 multiplied by 4. You get 11.340 milliliters. 11.340 milliliters. 11.340 milliliters. And this is the volume that will have to be infused over the next 24 hours. Yep, over the next 24 hours. And this is milliliters. It's like 2 gallons, right? Almost 3 gallons of water will have to run into them. And you will run 1.5 in the first 8 hours. You will run the second half, the remaining half, which is like 1/4, in the next 8 hours, and the third half, the remaining volume, the remaining 1/4, in the next 8 hours. And so the interesting thing is, you always break your infusion rate by 2. You divide your infusion rate by 2. Let's say so you have to infuse 5,820 milliliters, your gallon, in 8 hours. Oh. Okay, what am I writing? To infuse it over, okay, let's see here, 8 hours, to get milliliters per hour. Again, calculator. Calculator. So you get 508.20 divided by 8 equals, shoot, that's a lot, 725 milliliters per hour. Well, let's round it up. Okay. And then, so you infuse this rate here. And then the next half, the half of this half, so half of 508.20 liters, you will have to, the half of that, hold on, you have to divide it by 2. So let's get the calculator back. Let's see. So 820 divided by 2 divided by 8 hours. Doesn't sound right. Okay, 5,820 divided by 2. Get this number and divide by 8 hours. So you get 364. Okay. Oh, okay. It's not this, it's 290 something. Okay, we have another 370 that we have to infuse over 364 milliliters an hour. So we get 364 hour. And then the last one, gosh, it should be half of this. As much as I remember. Maybe the time is longer. Oh, alright, 364 milliliters an hour. For now, I gotta double check this. Check. But anyway, I'll continue for now. I gotta look it up. So again, as I talk, burn to the perineal area would be more high risk for the infection. Ah. Come on. Come on. The last thing is signs and symptoms of burn to the face, and signs and symptoms of damage to the lungs. So, by the way, if you ever asked the reason for why patients have acute respiratory distress, you can always say pulmonary edema and pneumothorax and pulmonary embolism. And so I chose to say pulmonary edema that can appear in the first 24 hours. They might come in without pulmonary edema, but it will develop and cause acute respiratory distress syndrome. History of being, so you have to ask them, have you been burned to the face? Have you been in an enclosed area where things were burning? Enclosed space have increased risk of carbon monoxide poisoning and hydrogen cyanide. Also, you will assess their airways. Signs of singed hair. Singed hair, 100% they have lung injury and they have to go through all this stuff, the intubation. Preferably oral tracheal intubation, not the thoratracheal intubation. Soot around mouth or nares. Is it black? Check for that. Carbonaceous sputum. Is their sputum looking black and grayish? Also sign of airway damage. Burn to the face, lower face and neck. If their neck is burned, in about, I don't know, 12 hours, let's say 6 hours, once they start swelling, once the blood vessels start leaking, it will swell so bad. One thing, it will swell so bad, and then also this, if that's turned leathery and inelastic, then they won't be able to breathe and it will be much harder to intubate. So if you notice any of this, they have to be intubated in 2 hours, 2 hours after admission. Just intubated. It's better to intubate them when they're able to talk and breathe on their own instead of later when the whole thing swells up. Then you initiate intubation. It will be too late. It was much harder. They most likely will have to go through the trachea, and just not the good choice. So burn to ears and nose are susceptible to infection because of the poor circulation. So poor circulation, higher risk of our green pellets to cause a problem. Okay. For some reason I can't select the green. Anyway, higher risk of infection to the nose and ears. Infection and infection because of decreased circulation. Oh wow. Changed in the middle of the writing. So also ask them the questions. Were you in enclosed space? Were you inhaling carbon monoxide? So signs of lower airway obstruction would, lower airway damage would be the stridor, hoarseness, dyspnea, and persistent hypoxia. So if they experience in stridor, you can hear the gurgling. If they are hoarse as they're talking, if they're short of breath, or their pulse oximeter shows low reading, which it might show a good reading, but they really have a bad reading because of the carbon monoxide. So it's a sign of damage to the lower airways. Okay, I think I laid out everything I had for diagnosis and assessment in this video, and I hope you found some new information or had some questions that you wish to dive into and find the answers for them. Thank you for watching and have a good day.